right. Hi, guys. It's Wednesday, January 18th, 2022. And it was a very lovely day, Wednesday, filled with consults and fun. And as Wednesdays are normally hump day and very difficult and sometimes miserable, where I have to drink coffee, and I never drink coffee almost. Today was very easy. I had the nicest people ever, and they were the greatest, and it made life very nice. So I had a lot of different issues, and actually a lot of patients that I referred away to other doctors because there were several other things people could do better than me. But a few things came up today repeatedly about different areas in the face that people didn't understand in facelifting or skin tightening or that kind of stuff. And it was actually about the glands. So, and hello to everybody from Dubai and Monterrey and Qatar and of course my sister. And so the glands of the face, I think, are not always fully managed throughout aging. And the glands that I'm talking about are both salivary glands and tear glands. So very similar, and they tend to descend over time and get bulky. So the salivary glands, so everybody knows, we've got three major pairs of them in the face, and that's the parotid gland, which extends from here. So this is the masseter. So people get it. The masseter goes from here and attaches on this flat little eminence down into the gonial angle and right around the jaw right there. That's called your masseter muscle. So when you clench, it's this rectangle here that's flexing. When you have a bulge behind it that comes down right over here into the neck, that's called the parotid gland. So the parotid gland is, Dr. Gawami, what's up? So the parotid gland over time tends to enlarge on many people, and it produces a different kind of saliva than the other two paired glands. But we have our parotid gland, have our submandibular gland, and we have our sublingual gland. So those are the three pairs of glands. Then we have your minor salivary glands, which there are hundreds of, and those are the ones that, if you look inside your mouth and it's wet everywhere, there's little tiny grape-like clusters which produce the saliva for those. There's mucinous, there's serous, there's seromucinous, which means some of the glands produce more watery saliva, some produce mixed saliva. The parotid gland is the one that empties out into here, into the cheek, into that little area which we call Stenson's duct. The submandibular gland is this one, empties out into the sublingual caruncle, which is that little duct at the base. Sublingual gland empties out in the sublingual ridge, which is lateral to that. So it's got multiple openings over there. So sublingual gland, don't worry about it for aging. What we worry about here is submandibular gland and parotid gland. And for the eye, it's the lacrimal gland, which is the one that makes tears and makes you cry. And the lacrimal gland is sits up here in the lateral part of the bone. It's in the lacrimal fossa, which is just a little bit of an indentation on the inside of the bone over there. What you see with the lacrimal gland, I'll just get out of the way quickly, is a hooding, a bulging on the side of the eye, and it tends to cause a fullness here that even after upper blepharoplasty, if not identified, leaves a little bit of a fullness. So if you're dealing with a doctor who knows what they're doing and does a lot of these, then they tuck it back in at the same time with something called a lacrimal gland pexy. The way to know if that's what's happening is you pull someone's eyelid up, you have them look down like that, and their lacrimal gland, if it's ptotic, is going to bulge out. So if you go like this and you look down, it'll be ptotic, and this pressure you put on the eye ensures that it kind of comes out. So you can always tack that up if needed. You don't want to do anything else to damage the gland. But the gland put tears out here, goes into your eye, empties out into these two little puncta ones down here. One is up there, and they drain into the nose, and that's why when you cry a lot, you might have a little sniffling at the same time, so it goes in into the nose. So we are not saying glands penis, we're saying gland, and Laura just joined. So back to these glands. What happens with aging? Largely misunderstood. So first off, when patients come in, and this is what happened today, everybody thinks they have fat in the neck. Everybody thinks, and so they all want lipo. But you can't do liposuction on people who don't have any fat. It doesn't really help them. And that's the case with all these people. They have fullness in what we call the floor of the mouth. So all that stuff. You look down over here, it causes fullness over time, just like it does on me. And that comes from submental contents or sublingual stuff, or floor of the mouth volume, which is submandibular glands. There is a fat pad and lymphatics, which are lymphatic fatty areas that are around the submandibular gland that wrap it medially. The submandibular gland wraps around the mylohyoid muscle, so there's part above, part below, and sometimes extends down. So it can even go below the hyoid on some people. And then you have the anterior digastric muscle, which is the muscle that extends from here out to the lateral hyoid, which is right here, and then goes up to the posterior digastric to the mastoid. That can get hypertrophic and full over time. And then you have the submental fat pad right over there, which is subplatysmal. The biggest mistake I see is people performing liposuction on people who don't need liposuction, because they tend to try to get rid of fullness on somebody who doesn't have fat there. And the way you can tell is by rolling the skin. So if you roll the skin over here on the face, you can see there's a nice little fat layer. In the neck, it's the same thing. If you don't feel a big fat cushy layer, you shouldn't lipo it. So what do we do about full submandibular glands? Number one, do they descend or do they grow over time? And plastic surgeons have studied this, and they've taken MRIs and CAT scans to show it over time. And it is a fact that most people actually show descent of the gland over time. So it descends from here, which is tucked up in what we call the submandibular triangle, which is between kind of inside the digastrics, comes down over time and come lateral to the hyoid and inferior. So that's descent, versus hypertrophy, which is growth. Some people do grow, some people do hypertrophy. It's not 100% of the population though, maybe 15%, 20%. They actually hypertrophy, and in those people you have to figure out how to shrink the gland. Same goes for the parotid gland. As we age and the platysma and SMAS comes down a little bit, the parotid has less of a covering and it tends to protrude. And what we see is a bigger bulge here. It looks fatter, so you get less jawline definition, more just fullness. And then you get parotid tail fullness, which is down over here. So if you feel the bone behind your ear, that's called the mastoid. If you go right in front of the mastoid, that's the tail of the parotid. It's attached. And if you go down, it extends down into this triangle where the sternocleidomastoid is. So that's the tail of parotid goes down there, and that becomes more prominent and enlarged over time on people as well. So non-surgically, if you want to get rid of this or diminish these things, you can use Botox. Botox, there's a couple studies on it. There's one that came out in 2019, was the last one that I saw. Putting in, I think they put 40 units of Botox, meaning 20 on each side of the submandibular glands. They used ultrasound, caused a 5 milliliter shrinkage in the glands. So they measured each one to be 15 milliliters, and it caused a 5 milliliter shrinkage, meaning it went down to 10 milliliters. That lasted 100% for 1 month, less for 2, 3, 4, 5, 6 months. It was back to normal. So it does shrink the gland. You can shrink it. You just have to repeat it a bunch of times for the gland to atrophy. So you just inject into the glands there with Botox and you can reduce them. Same goes for the parotid gland. A lot of people don't know that. They actually mistakenly inject the parotid instead of the masseter. I've had people come to me saying they have masseteric hypertrophy, which is that muscle there, and it actually has no hypertrophy, but it shrank down when they put in Botox. And I told them, you actually Botoxed your parotid gland, not your masseter. Your parotid was big. They say, oh my God, but why would it work there and not on muscle? And the answer is because it works on glands as well, just like it works on sweat glands. So you put in Botox into the parotid gland and it can shrink down. What can go wrong when you do Botox in the glands? Here, almost nothing. There's not much to worry about for musculature there or nerves that attach the muscles. Down over here, you can actually hit, if you hit it incorrectly and don't hit the gland, you can hit the mylohyoid muscle and the surrounding muscles of the floor of the mouth, and you can cause a little bit of dysarthria, meaning the tongue and the mouth can kind of feel like they move weird. Nothing severe, but it can happen. So you can put in Botox here, you can put in Botox there, and it'll shrink it a little bit. What do you do surgically? So surgically, starting from here, you do the pexy, right? And this happens more in people who have Graves' orbitopathy or prominent eyes. So if you see people with like bulging eyes, they almost always have the lacrimal gland popping out because it was pushed out just like their eye was pushed out. Down over here and here, you have to do a facelift or a weekend lift. And the idea is to resuspend the floor of mouth contents and to put the parotid gland back into its place. So This is the special thing that we do during surgery, is going in here, and even though we're not trying to do a platysmoplasty to tighten things necessarily, we go and we contour the submental contents, which means through a small incision under here, you go down, you elevate off the platysma muscle on each side, and you can go reduce the digastric muscle if you want. You can go reduce the submandibular gland. The big mistake people make is trying to reduce too much because they don't know how to lift. So if you know how to lift, you don't need to reduce much. You reduce like whatever's tautic or whatever's below the hyoid or whatever's enlarged and pushing into the hyoid. Most people try to go after more than that. They get bleeding problems, seromas, all these different things. So during my standard facelift, I'll always take a look, and if the submandibular gland has a little bit of pooching or something, I'll just trim it, and it's very, very easy to do. Same with the digastrics, and same with the submental or submandibular triangle fat pad. Laterally over here is a little more difficult. So if you look at all my facelifts, you'll see that there's pretty sharp definition here, and bulges or fullness here are always pushed in, which makes people's necks look thinner from the front. And the way I do this is by releasing the platysma off of the sternocleidomastoid, going up, and then pushing the parotid gland back in after it's released from the mastoid. So I do something called the mastoid crevasse. I release the parotid gland from the mastoid. That makes it loose, and then you can go grab it and actually push it back deep. So you don't need to do much other than that. I do what we call a parotidectomy, which is I go to the tail of parotid and I actually cut some out sometimes. So either way, back to the lesson. I advise these patients that the lipo on them did not work, nor did the face type, because it wasn't fat they were trying to get rid of. So patients aren't doctors, and we call them lay people. And so lay people don't understand really what's happening internally. So everything to somebody who doesn't know about it is either collagen or fat. And that's what everybody thinks their faces are made of. So there's more than fat underneath. There's muscle, there's heaviness in skin, there's a million other things that are in there. And in the face, there's certainly more than collagen in the skin. A lot of doctors simplify it like that too, and all they think about is fat. So what's wrong with doing liposuction on somebody who doesn't need it, who has fullness, is that it actually changes the contour in a nasty way. So somebody who's rounded and has submandibular gland fullness, if you lipo them, they get flattened and they look boxy, and then they're still full there. So I would have actually preferred to have these people left rounded. You can fix it with surgery, but that's where it happens. The other thing is a lot of these people that have fullness here also have weighted submandibular muscle. So like the platysma under here and the digastric, both of them are weighted down along with the submandibular gland. And when you take away the fat, it exposes it. So they actually get worse after doing liposuction. So you end up, again, getting broad, banded, and descended. So then they have to go do a facelift or a neck lift to fix that. Then patients were asking, what's the difference between a facelift and neck lift? I've mentioned this many times. Depends who's doing it. In general, a facelift is a neck lift, is a facelift is a neck lift. They're the same exact thing. And the difference between one facelift to another is the name and the person doing it, and the before and after photo. So today I had several people ask me, is this a lower facelift or what is this considered? And I try to explain the facelift that I do is considered a mid-face to neck lift, which is the best way to address all the stuff that I'm talking about, because you can release everything and reposition it properly. But that's a talk for another time. Let's see if there are any questions. I hope it made sense, but don't forget the glands was the kind of idea. So my surgery's in a month. Da, da, da. How do you feel about doctors who do hyaluronidase? Can't cause destruction. Hyaluronidase is great to use. Anything you put in the face can cause destruction. So hyaluronidase is one of them. It's I think most people understand if you put a steroid in the face, it can cause a problem. If you put a needle in the face, it can cause a problem. If you put a needle with something in the face, it can cause a problem. Hyaluronidase is also one of those things. So it's surprising that people think it would be harmless. Nothing's harmless. I wouldn't say it's harmful though. So does using many stitches cause more scarring? No, not really. So scarring is caused by tension for the most part, not caused by stitches. Stitches, if they stay in for too long or too tight, yes, you can leave track marks and get hypertrophy, get dermal bridging, epidermal bridging, get a lot of weird things with it, and loss of pigment. So not a lot of questions here. You and Dr. Gavami are two of my faves. He is great. All right. Glands, questions, da-da-da-da-da. All right, not many questions here. And that's it. So I will sign out. I will post this. If anybody has any questions, you can always come stop at the office, which I just learned, again, that my wait list is painfully long, so I do apologize to everybody, but I'm working as hard as I can. So happy Wednesday.